Neuromuscular fatigue, a diagnostic challenge. Interesting topic. Please go ahead, Rajat, you start.
Sure. Can everyone see the slides and hear me okay? It's great. Can you guys hear me?
Yes.
Okay,
Yes,
perfect. All right, great. So we're going to start off with, thank you so much, Dr. Ahmed. It's such an honor to be here. I'm so excited. Today I'll be talking about a topic called neuromuscular fatigue, a diagnostic challenge. This is a topic that's near and dear to my heart, so very important. Now, when we talk about neuromuscular fatigue, we really talk about straightforward neuromuscular fatigue. And everybody here, or those who have studied neurology and had to take their boards, the first thing we think about is, our straightforward myasthenia gravis. And this is a cartoon of a motor nerve trying to communicate with a muscle, and there's problems, and they need more acetylcholine because for those that are not familiar with myasthenia gravis, this is a disease where there's antibodies that affect the transition from the motor nerve to the muscle. So this is a problem, but today's topic is not going to be straightforward. You see the word challenge. And so today's going to be a topic about challenge, neuromuscular fatigue that is challenging. And why is this fatigue challenging? Why? Because number one, fatigue in general has so many differentials. When we talk about fatigue, we have we talk about problems with anemia. It could be anything, glucose, infection, set rate, CRP, anything that talks about inflammation. Pregnancy can cause fatigue. Fatigue can be caused by difficulty with sleep, exercise, lack of exercise, depression. Any body system can cause fatigue. And so we're dealing with a humongous differential. This is not even limited to the heart. Just imagine someone has a heart attack. That can cause fatigue. Issues with the lungs. So it just goes on and on. Malignancy, issues with the immune system. So when we talk about fatigue, it's so vast. When patients come in, I don't even know where to start. And I make sure they've had their basic checkup. And it reminds me of the analogy of the blind man and the elephant. Here is when we're blind and we're touching an elephant, we can feel many different parts. Some people can feel the tail. Some people can feel the trunk. Some people can feel the tusk. And all of these can be different parts of the same thing. So many differentials in fatigue. The second part of the challenge is that it's described in different ways. And this is really part of when I see a patient, it takes forever because they come in with the most confusing symptoms. They can come in with soreness, pain, shortness of breath, twitching, trembling, everything falling out. Hold on one second. Everything falling out of their hands, muscle cramps, legs that are floppy. They want to travel, but they can't. They want to exercise, but they can't. And they have so many problems. They even have muscle knots. And so a lot of times routine testing can be negative. They have no objective signs at the time. They have an EMG and a nerve conduction study and a biopsy that can be negative. They have soft signs and complaints that are really hard to navigate. Patients can be so frustrated. It's a huge diagnostic challenge, especially when it's not as straightforward case like myasthenia gravis. The complaints and disability are out of proportion from the physical exam. And it's such a problem that it can be a neurologist and a patient's worst nightmare. So how do we get insight on challenging neuromuscular patients? What are some diagnostic clues to patients who present predominantly with neuromuscular fatigue? And a lot of times they're saying they're just so tired all the time. So we have a really, really big problem. And how do we get some sort of resolution to this problem when they're just telling you all the time that they're tired and you have no idea what's going on? Oh, sorry. Sorry about that. That was just a technical difficulty. So I just got paged here. So we're going to say, so these patients say that they're tired all the time. So we've got the first case. It's a 35-year-old acrobatics instructor. She has numbness up to her knees, in her face, abdomen, tongue, and fingertips. She excruciating cramping and pain in both legs to the point of tears. She stated, I can't go grocery shopping without having to lean on the cart the entire time because of the weakness in her legs. It's even too hard to climb stairs. Prior to her symptoms developing at age 26, she was an active lifestyle. She taught acrobatics for 30 hours a week. So she was so active, and now, she was so active and she can't be active. So now that was a big change. And so her symptoms included difficulty with balance and coordination. Unfortunately, she had such severe body aches and pain. It became so severe that she was not able to continue with her active lifestyle or acrobatic career. And it's interesting, her family history was unknown. She had a past medical history of pulmonary embolisms, cerebral vascular disease, benign hypertension, and psoriasis. On her physical exam, she had decreased pinprick and vibratory sense loss on her shins and calves bilaterally. Her neurological gait and coordination were intact. Her reflexes and strength were normal. She had no weakness or scapular winging. She had no exertional weakness on bedside testing. Majority of the physicians would have just kind of said, what is going on? This is really confusion. She cannot do her acrobatics anymore. She's having so much pain to the point of tears, right? If you look back in her history, she's actually can't even go grocery shopping. She has to lean on the cart the entire time because of the weakness in her legs. It's so hard to even climb stairs. And so that's an issue. So we did a workup, and I did a very, very thorough workup, and that showed a possible myopathy of the upper and lower extremities. The myopathic units, if anybody remembers, they're very small with early recruitment. And of course, I did repetitive nerve stimulation, which was normal. So that was a clue for her. We continued her workup, and I remember the day we got her vitamin D level. It was initially low, but it was retested and became normal. I told her, I said, please have your vitamin D because I hope that makes you feel better. We did other things like a CK, checked a calcium channel, and a voltage calcium channel antibody for LEMS, a paraneoplastic panel, a striated muscle antibody, a voltage-gated, potassium channel antibody, acetylcholine receptor antibody, a myositis panel. All these things were negative. And so does anybody have any idea of what's next? If anybody wants to chime in, or I'll just go ahead. Anything there? Any clues of what's missing or anything we'd like to add? All right, so one of my favorite things to do is genetic testing. And we did a comprehensive neuromuscular panel, and this patient had a heterozygous pathogenic deletion in the dystrophin gene, exons 49 to 51. This was associated with Duchenne and Becker muscular dystrophy and X-linked dilated cardiomyopathy. So a lack of the dystrophin protein on the X chromosome in the muscle cells causes them to be fragile and easily damaged. Boys have one X chromosome, so with this mutation, they exhibit muscle weakness at age 2 to 3. They have difficulty jumping, running, and walking. They have calf enlargement, a wobbling gait, and lumbar lordosis. They also get this progressive weakness and scoliosis. Sometimes in the clinic, I'll just have them skip for me. It's very sad. These are very cute little kids that just can't really jump. They can't really exercise. They, of course, have impaired cardiac function. Now, one of the things that we think about female carriers, they kind of have variable symptoms. But if we think about textbook cases, Duchenne carriers are females. They usually have a normal dystrophin gene on one X chromosome, and the other X chromosome, it's abnormal. And in the textbook, this is what this talk is about. Most of the textbook cases of those people who have Duchenne muscular dystrophy, common 80 to 90%. When you think about these patients, these are females. they are going to be asymptomatic. This is what we are learned in textbook. But in this patient, the rare, uncommon, the challenging cases, these carrier females can be symptomatic with pain and exertional fatigue. And looking back at this patient's case, she had numbness all over her body and she had a neuropathy. I don't know what that's about. I think over time, as we go in the future of neuromuscular medicine, we may be able to learn more about carriers. And sometimes, they can have pain just because of the muscle issue. So it's hard to understand what that neuropathy was, but we'll be following that as well. She also had, a pulmonary embolism as a young child. It's hard to know what that was from. But it's interesting, really great team. I see Jennifer here, Jennifer Pagano and Brian, who's our medical student. Laura Patrick and I published three cases with, who had exertional weakness with Duchenne. There were Duchenne muscular dystrophy carriers, and the carrier had a dystrophin mutation, and all of them had exertional pain and weakness. And a lot of them didn't have any focal weakness. So very interesting. Case number 2 is a 13-year-old girl. She's a future basketball star athlete.
Neva?
Yeah?
I have a question for you.
Yeah.
Before the next case. So,
Yes.
So was there any family history knowing that this is probably the woman was carrier, but did she have any children or sibling, like male sibling? With history of...
And I remember her like it was yesterday. Family history was unknown. I remember her so well because I remembered forever asking her over and over again what her family history was. So, and
Okay.
she had a kid who was not affected. So really interesting case. I don't think she had any children affected. So yeah, very good question. That's my favorite. So 13-year-old girl, future basketball star. This is an athlete. In the summer months, she developed tightness and heaviness in legs, describing exertional fatigue. So she had no problems as a child with running or walking, no family history. She took no medications and had no medical problems. Her physical exam, she was completely normal. She had subjective pain when asking to jump, skip, or run in the hallways. So on the exam, I'm just perplexed because she looks normal. And I asked her to jump and run, and she's like bending over saying her legs are hurting. She had no weakness or scapular winging or difficulty with getting up from the floor. She had no exertional weakness on bedside testing. And the majority of physicians would have probably just said, hey, it's a summer, probably growing pains. I don't know what this is. There's nothing objective. And it's so interesting that she went through a huge pathway because she went to her pediatrician. And the first thing they did was they ordered an AST and ALT, a routine workup, which was high. And that prompted them to do a CK. The CK was very high at 31,000. Your normal CK is less than 200. The MRI of the lower extremities showed actually, this is a very novel thing that people are doing now, is to show edema and swelling in the muscles of the pelvis, thigh, and the legs. They thought it was nonspecific, but consistent with juvenile dermatomyositis. So you have a radiologist leading you to a pathway of juvenile dermatomyositis. There was no fatty atrophy of musculature noted. She had a muscle biopsy of the proximal right lateral gastrocnemius that showed inflammatory changes, and there was a negative for dysferlin. Now, that was so interesting. Now you got another confusion. You think this is inflammatory. So they thought they put her on a steroid trial. And for 6 months, she had no improvement. So, of course, my favorite next step, I'm sure you guys
Genetic
can get
test?
it. Yay! Thank you, Dr. Lee. No problem. Thank you. It's genetic testing. She had 3 abnormalities in the dysferlin gene. She actually has 1 pathogenic and 2 variants that were predicted to be pathogenic for dysferlinopathy. So really interesting case. So what is dysferlinopathy? It's autosomal recessive. I'm sure many of you may not have heard it, but it does cause a problem with membrane repair and vesicle fusion. It can present with distal weakness as Miyoshi myopathy, or even a limb girdle muscular dystrophy type 2B with proximal weakness. There's a high degree of variability in the weakness, but it can present with exercise intolerance. It can have muscle edema. So it's very common to see dysferlinopathy as an inflammatory myopathy, just like this patient had. So there are atypical features reported, and just like all of neuromuscular medicine, the patterns are still to be recognized. You can see here how dysferlinopathy causes inefficient repair. And you can also see here how there's distal weakness and atrophy, and there's inflammation in the calf. So very interesting case. This guy's a 40-year-old gentleman, and the calves are completely gone. So what we see in dysferlinopathy, it causes limb-girdle muscular dystrophy, and that's what we think about in the textbooks, at least in our world. But what we have to recognize is that there are uncommon, rare, and challenging presentations of dysferlinopathy, which can cause exertional fatigue, and it can cause high CK and variable findings, as we see in our patient. So what we have to see here in this case, and I think when we say common versus uncommon, we're thinking textbook versus not textbook. You know, I think we're thinking about things that are different. And I think this is the trend of neuromuscular medicine. We don't recognize, we call it uncommon, but I bet you, 20 years from now, these are going to be more common. So it's just that we don't recognize it very often. And I think that's the trend of how things are going to be moving. All right, so case number 3, we have a 57-year-old woman. She is an avid Pilates exerciser. She presented with pain in her shoulders. This is really interesting. I saw her, she still follows me now, but I saw her many years ago at University of Florida, and she told me she had an ache and sharp pain that despite exercising every day while doing Pilates, she had this kind of fatigue in her shoulders. She had tightness in her shoulders, pain when doing her hair, and her hands would ache. She had no problems with chewing or swallowing. She had no problems with walking or falling. She had no foot drop or dragging her feet. And I spent quite some time, and she said her physical exam was completely normal. She had no scapular winging. She had no weakness on exertion. She had no overt weakness, but just a little bit of pain when she lifted her shoulders. And again, majority of the physicians would have said, why is she here in the neuromuscular clinic at University of Florida without any sort of weakness? What is she going on? So I said, okay. I said, why don't you get an MRI of your cervical spine? Why don't you get an EMG of your arms? And then we'll figure out the next steps. And so she was like, okay. And I told her, I said, am I missing something? She said, no. And as it is classically with most of our patients, as they're leaving the door, she has to tell me something. Was there some aspect of her history that's missing? Given the theme of this talk, can anyone tell me what's missing in her case? What did I not mention? She's pretty normal. She has muscle pain in her shoulders. Now,
family history?
Yeah, Dr. Lee, you can give this a wow. So she's family history. As I'm leaving, she told me she had a family history significant for FSHD. She said I said, what? Now that was another half an hour of discussion. She started crying. She said, I'm so scared. Her daughter was okay, but her son has shoulders that are drooping. So I immediately did an EMG, and I just had to do one left trapezius, and I saw fibrillations and fasciculations, and I knew that she probably could have it. So I sent her for genetic testing, and she had 7 to 10 repeats for FSHD. So she was positive. Now, FSHD is facioscapulohumeral muscular dystrophy. It is like it's like muscular dystrophy that we are all talking about, but now it involves the face. So that's your key diagnostic clue. It involves the face. It also involves the shoulder, arm, trunk, and leg. People will have scoliosis and scapular winging. It's the third most common type of muscular dystrophy behind Duchenne and Becker and myotonic dystrophy. The estimated prevalence of FSHD is about 4 per 100,000. But if we tested a lot more of our patients with shoulder pain, we might be getting more, because a lot of times we're not. If she didn't tell me her family history, I would have never thought about this. Now, very commonly, you can see these patients have weakness in their mouth. You see this lady trying to pucker, her mouth is weak. You can also see there's an extra axillary fold underneath the armpit, so they're weak there. This is very interesting. I see very commonly, you'll see this biceps is weak. It kind of creates a Popeye form, and the forearm looks okay. And then you see an asymmetric scapular winging here. So that is also part of FSHD. In our patient, she had none of that. And she continues to have none of that but pain. So more than 95% of patients have FSHD type 1, which is characterized by deletion of large repeated elements on on the long arm of the chromosome 4q, the D4Z4. Healthy individuals have more than 10 repeats, and patients with FSHD type 1 have between 1 and 10 repeats. Patient had 7 to 10 repeats, which is the milder phenotype. So if you think about FSHD type 1, it is a repeated element on the long arm of chromosome 4q. It's the D4Z4 region. What's hard about this is that we always talk about trinucleotide repeats, right? But with FSHD, it's a deletion of repeats. And so the fewer of these repeats, the more severe you are. In other cases, the more repeats you have, the more severe. But here, the fewer of the repeats, which the repeats are protective in some way, then the more severe you are. So these healthy individuals have more than 10 repeats, and patients with FSHD type 1 have between 1 and 10. So she's close to the normal level of repeats between 7 and 10, which is she's milder. And it's important, if you're looking for this, your routine genetic panels do not have it because it's a deletion of a repeat D4Z4 gene. So you have to kind of go for it. And I've seen some people that even if they have the gene mutation, sometimes, and they have the family history, sometimes it's still very, very hard to get the mutation.
So Niva, in this case, so you talk about a deletion instead of mutation. So do you routinely order CMA in addition to gene panel, or what is your approach? Just thinking that potentially FSHD is in your differential.
I'm sorry. What did you mean by CMA for this? Do I
the
order
chromosome microarray, because it's a deletion. So either your gene panel or whole exome sequencing will not necessarily detect this.
100%. No, we have a specific. We typically go through a specific lab in Utah, and that lab does that sort of. They do. I believe they do the special testing for FSHD. So I don't go that way. I go specific, and it's free for our patients. But yeah, we definitely have that done. And the way I do it is very clinical. So as soon as I see facial weakness, I'll almost automatically think about it. So I'll order the neuromuscular panel, plus in addition, have them get their genetics done through Utah. I know Jennifer is here if she wanted to weigh in on anything.
Yeah, I was just going to say, Dr. Lee, it wouldn't be detected on most whole exome, whole genome, or CMA. It has to be like a specific repeat expansion test. So either like a repeat primed PCR or long read sequencing. So it is really difficult to get this type of testing for patients.
I see. So you have to have a specific differential diagnosis and send it to a special lab like Utah.
Absolutely. Right. Yeah. Usually we have a family history, but in those cases, I think there's quite a few that don't. I'll have the facial, they'll have a neuromuscular panel that's negative, and then I'll do their testing and I'll know right away it's their face is weak. And that's really what gives it away, especially the eye closure. So very interesting. It's hard. I think a lot of the FSH, I had another one that had difficulty. He had really almost normal. He also had shoulder pain, but just a touch of shoulder weakness. And those people, he apparently, he went to another facility and got tested for it. So it's really, I think, a little bit under-recognized, unfortunately. I think that's very common. All right, so now we're going to go into textbook versus not textbook. So common versus uncommon. So in around 90% of FSHD patients, this is what we read in our textbook, is that we have patients who are dealing with symptoms before age 20. And this is what I think a lot of physicians and neuromuscular physicians are not very familiar with. If they see FSHD, they're thinking of weakness as a child, weakness when they were growing up. Now they have asymmetric involvement in the arms and legs. And this is a lady who has this uncommon, rare, and unique presentation, probably because she has more repeats. She has a late onset presentation with pain, fatigue, and no weakness. And as I said, she continues not to have weakness. She just continues to have severe pain and continues to do her Pilates throughout the pain. So just a great learning lesson for all of us that, people coming in it's not always just, very straightforward. So case 4, this is a 29-year-old woman who was an active and a fast runner as a child. She had scoliosis at age 9, surgery for the scoliosis at age 22. She had an extensive, painful recovery. She had cramps and significant pain. When I saw her, she had head pain, jaw pain, neck pain, eye pain, and muscle pain that was so severe that she would pass out. I don't know if anybody has had a patient that had such severe pain that would cause them to pass out. Wow. And then she's so tired that she couldn't drive or chew food. All her muscles hurt. She kept saying, I have no idea why she has this. She just had no idea. She thought she was a runner as a child, and now she was not the same person. She had a very thin, frail body. Her muscles were not developed well. She had no focal deficits, but she did, if you look at this, she didn't have the muscle definition, but she definitely had a very thin body. It looked almost like a skeleton. I continued to ask her questions. Her dad had mild scoliosis. Her younger brother had arthrogryposis. Her mom had skin cancer and had passed away. Her cardiac evaluation was negative, although she had an irregular heartbeat in the past. She was evaluated for dwarfism, and her workup was negative, and her CK was normal. As always, our workup is not really revealing here. So obviously, my favorite next step, if you've gotten the clue and the theme of this talk, and obviously the past 3 cases that we talked about, my favorite next step is genetics. And she had a TTN mutation she had a mutation in the Titin gene, one pathogenic, one variant, and it can present as autosomal dominant or recessive. What is Titin? So Titin is the largest protein in the human body. It is located in the muscles. It's part of the sarcomere, so it's involved in relaxation, contraction. It supports the architecture of the muscle cell, and so it's a really important part of the muscle. So that's why her muscles were not developed very well. The clinical features of a titinopathy are variable. This includes hypotonia. So she, didn't really have much tone, and I would agree with that. But it also includes contractures, sometimes the eyes, the ophthalmoplegia, scoliosis, was what she had, respiratory insufficiency. It's incredible. I've had patients with titinopathy who just came in with breathing difficulty. And they just had shortness of breath, and I thought it was their heart, but then 4 or 5 years later, they developed a foot drop, and I was like, oh, check neuromuscular genetic panel, and they had that. A slowly progressive limb weakness, cardiac involvement at 46%, and then CK levels, again, can be misleading because they could be normal or moderately elevated. So titinopathy is a huge protein, a lot of different presentations. Salin myopathy is myopathy in newborns, different muscle diseases with respiratory failure, limb girdle muscular dystrophy, tibial muscular dystrophy, early onset myopathy with fatal cardiomyopathy, muscle weakness, a lot of different phenotypes here with the heart and, some limb girdle processes as well, mini core disease and central nuclear myopathy. So a lot of variability. So this talk, so it's really important that if you suspect neuromuscular fatigue is very difficult because it's a vast differential, presentations are difficult. A lot of time testing can be normal, especially in those cases that are not myasthenia. It's very, very, very important to get a patient history. You have to get an exam, and every detailed observation are crucial. It's just everything is so important. It can be a challenge, especially when you can't find a diagnosis, but this is something creative. Now, this is very creative. I love to push the envelope. I love to go above and beyond and think of things of how we can move this field forward. So if you think about it, I called it the Dr. Niva flip. Now, this is one thing that over the years of seeing thousands of patients will come into my clinic. I'll be their last doctor. They'll come from all over the country. And I wonder, what is it that I offer? It's because I can tell if it's a neuromuscular issue or not, just based on this one concept. It's a flip. So they go from normal. If you see this theme, our acrobatic instructor, our basketball player, our Pilates exerciser, our runner, all these people had like kind of a normal, lifestyle. And all of a sudden, over time, they had exertional fatigue and pain. They didn't have anything else going on. nothing like anemia or cancer or anything like that. And then they were getting tired. So it is the flip. So that gives you a sign. It tells you this is something authentic rather than depression. There's something else beyond, your straightforward cases. They really want to go out and do something, but they can't. So some of these got clues. The first one, we had an EMG that was slightly abnormal, but it was very hard because it was operator dependent. So if you send your patients to get an EMG, not all of them will be abnormal. The second one had you had a CK, it was like 31,000. The third one had a family history of FSH. And the fourth one had scoliosis and poorly developed muscles. But all of them were tired, so it makes it difficult. But the flip is important. And then you always think about this fatigue involving muscles and exertional weakness. The weakness occurs when they do something. So they say they're weak, but it's usually when they're doing something is when they're weak. And when you do see patients like this, consider neuromuscular consult, an EMG plus genetic testing. And you can now do MRIs of the muscle. It is important to accept the time commitment and challenge. Definitely not an easy thing to deal with in your clinic. Patients are frustrated. It's very, very hard to go through. And again, when we talk about neuromuscular fatigue, this didn't go over the cases that were a little more basic, like myasthenia or Lambert-Eaton. Mitochondrial is still a challenge, but sometimes there are a little more clues on that one. But still, all of these are hard, and autoimmune diseases as well can cause fatigue. So just a quick overview of my life in the neuromuscular clinic. I know this was a brief one, but any questions, anything to open up a discussion or anything that you guys would like to talk about?
So I can start with a quick question. So how the MRI would be helpful in muscle diseases or muscle dystrophies? What findings you're looking for on the muscle MRI?
Absolutely. So when you're looking for the MRI, you're looking for atrophy, muscle atrophy. And in the dysferlinopathy case, there was inflammation, so it was misleading. But typically, we're looking for atrophy and looking for certain patterns of atrophy. There are now neuromuscular physicians who specialize in different groups of muscles causing different diseases. So limb-girdle muscular dystrophy, some of them will cause, have just calf atrophy, and some of them will just have quad atrophy. So that's where you see that there's something wrong with the muscle. So say they're saying muscle pain. When you get the MRI, you'll see atrophy, and sometimes you'll see inflammation. But that atrophy turns into fat, and that fat turns into white. So that's what you'll see in the MRI. Does that help? Yeah.
Thank you. Yeah, Dr. Lee?
Yeah, so thank you again for exciting and very stimulating talk. I really enjoyed. So my question is, well, we see a lot of patients, with epilepsy, and some of them actually have scoliosis, for example, and typically we send them to orthopedic surgery to kind of be evaluated, but I never really recognize also parts actually ordering genetic testing or EMG to find the cause of scoliosis. Do you think that should be part of the scoliosis evaluation?
I love that question because I always would think, is that part of scoliosis? But I don't see it a one-to-one always. I see a little more of I see scoliosis with fatigue, with atrophy, then I would do it, but not on its own. I don't see it's just like if you have pes cavus, you're not going to get the same problem. It's not always CMT, right? So same thing with scoliosis. You're not always going to have the same. I don't think everything scoliosis is neuromuscular, because don't you see it in some sort of epilepsy conditions?
Well, we see them after like hemispectomy. So there's an imbalance between the spinal muscle supporting the spine, and in time they develop actually epilepsy. But what I'm talking about is more of children with epilepsy, but there's a coincidental scoliosis, and we send them to pediatric orthopedic surgery and so on. So that was a really question. But I think you answered my question. Probably we don't have to always consider neuromuscular evaluation for that.
I love that question, though, because it's crossed my mind. I've used scoliosis as a clue for a lot of things. Do you ever see scoliosis very commonly with fatigue? Because if you see the two or muscle development, I think those might warrant a neuromuscular. You know, I
Got it.
just give you that, like, if the muscles aren't developed well, think about that. You might see that a lot in your world.
Thank you.
Thanks.
Holly, I have a question.
Yeah.
Hi. Great talk. Thank you. So I noticed most of the patients in your talk were athletes of some sort, and maybe for emphasis, but, and as we all get older, I guess we lose muscle mass, although exercise can help. Do you think we're missing patients with genetic conditions because they just don't happen to be athletes?
That's a great question, Holly. I do. I used athletics, but in my career, I've seen the change in people who are not athletic. And it's like they may not be athletic, but they may be a volunteer, or they might be a firefighter. And they have adopted. I had one lady who was a firefighter and she adopted 4 kids. She wasn't athletic. A lot of neuromuscular patients with neuromuscular disorders aren't athletic. These happen to be the case, but a lot of them will have a hobby or a passion, or they want to travel, or they want to do something fun and they can't do it. Or they're really, really active, not even physically, even if it's like at work. Do you know what I'm saying? And I think that gives us a good indication that there's something wrong as soon as that flips. As soon as they suddenly go from adopting 4 kids, which I had a lady who was a firefighter as a volunteer, and then she was on the couch within a few months. I knew something is wrong. And we found a central nuclear myopathy in that case, but those are hard, very hard. So, but I do agree with you. We should include ones that are not athletic, but it's the activity that's important. And some may be just born with it. And then they will probably, those are hard. Those are maybe mitochondrial, and it didn't go into that. So those are harder.
Understood. Thank you.
Dr. Rod?
Yeah, it's Dr. Rod. Thank you, Dr. Girard. It's a great talk. I want to check with you, are there any venue for treatment in these conditions? Has there been any advances so far in any forms of treatment?
I love that question. I'm sorry for the noise in the background, but I love the question about that. So for the Duchenne, I was just on a research call where they're doing a different molecule, and they're helping both. So right now for Duchenne, there's exondys 53, 4 exon 53 mutations. So if they have a deletion in exon 53, then you get those patients get treated. So, and they're boys, can't even have women. So there's now a molecule that's more generic, and I was working on developing a clinical trial for them because they were going to talk about expanding their product for adults, men and women with their carriers with that. So hopefully in the future, the Duchenne population is going to get treatment for the tendinopathy. There's no treatment yet, but I do know that there is a support group. So this little girl got into a beautiful support group, so she was happy with that. With FSHD, nothing yet, unfortunately. So hopefully we get that. That one's hard because it's a deletion, a triplet deletion. And dysferlin is long. We got a long way to go. So hopefully we get it, but there's a long way. Yeah, Dr. Lee?
Thank you.
So along the line of gene therapy theme, do you see the feasibility of in vivo gene editing at some point? Like, for example, for Duchenne, it's a point mutation. Is there any effort to try, like, CRISPR delivering into the systemic circulation so that it goes to the muscle and fix the gene mutation?
Absolutely. We have so much to go, so much to learn. I'm excited about that. So it's just a lot, but there's a lot to work through, especially in neuromuscular medicine.
Okay.
So, quick question about using like mestinon in these patients, pyridostigmine. I mean, some docs use for muscle weakness, even though they don't have myasthenia gravis. So, any experience using those drugs in muscle dystrophy patients? I'm just wondering.
I love it, Dr. Ahmed. So I do use it in SMA patients, and it works for a few, especially in mitochondrial. But the one thing I've loved is Adderall. I might write a paper on that. Adderall has really changed my patients' lives. That there's something about it that it's a cognitive function, but it also gives them some sort of muscle energy as well. And so I've been giving that quite often to some of these patients, and they have cognitive fatigue as well as muscle fatigue. So I think that medication is really helpful. It's been amazing. And so I love that question. I hope we get more treatments.
Do you
Thank you.
think caffeine helps in the same way, or maybe modafinil?
I haven't seen that help. Modafinil, yes, but not caffeine. Oh,
There's a
someone
question
has,
in the chat.
yeah.
Say, are we missing some scapular winging just because of the clothes people wear to the office?
I love that question. No, I'm very particular about it. But yeah, very, very picky. I'll make sure that I lift up and look. But a lot of people are. And if you see the FSH where there was a divot and there was like a bulge here, not many people look at that. So definitely needs to be looked at. We don't. And I'm very, very picky about it. So.
Okay. Any other questions? All right. So thank you, Dr. Gerard. I appreciate your talk and learn a lot today, but it's so complicated topic. There's so many genetic mutations to remember. I'm sure we'll forget a lot of them, but thank you for your talk again. I appreciate everybody's coming for the grand round. Thank you. Bye-bye.
Thank you all. Thank you, everyone. Thank you. Bye.
Thank you. Thank you, Diva.